Hello and welcome to my YouTube channel. Today we'll be discussing a very important topic, and that is a clinical approach to a patient of obstructive jaundice. I would expect this topic to be quite useful for MBBS students who are doing their surgery rotation, as well as PG surgery residents and interns who are doing their surgery rotationship. Without much ado, let's start with the topic. I would be covering this topic under the following heads: a brief introduction about what exactly is obstructive jaundice, a revision of anatomy of hepatobiliary system, especially the extrahepatic biliary tract, to understand the pathophysiology of obstructive jaundice, which is quite essential because it would help us in formulating a treatment plan and investigations which are required in such type of patients. A word about clinical features. What are the different type of investigations which we would do in a patient of obstructive jaundice? Treatment, and finally complications. In the end, I have basically given few multiple choice questions to understand this topic much better, which you can solve in your spare time and put it in your comment section. Now, what exactly is obstructive jaundice, which we also call as surgical obstructive jaundice, or SOJ in brief? As the name suggests, it is basically an obstruction to the flow of bile from the liver to the small intestine. And this obstruction to the flow occurs basically when there is a mechanical obstruction to extrahepatic biliary tree. This mechanical obstruction basically can also occur intrahepatic, but here we are more concentrating on extrahepatic biliary obstruction. And there are different causes of extrahepatic biliary tract obstruction, which we would see subsequently in our presentation. And if you know that this type of obstruction would basically lead to conjugated hypobilirubinemia, which I would be talking in more detail in my subsequent slide. Just to revise the anatomy of biliary system, basically it consists of the gallbladder, which stores the bile, and from the gallbladder the bile flows into the duodenum through cystic duct. This cystic duct joins the right and the left hepatic duct, forming a common hepatic duct. So cystic duct, when it joins the common hepatic duct, it forms a common bile duct, which enters into the second part of the duodenum, as this diagram suggests, at the ampulla obvata. We can also see that the main pancreatic duct also opens at the same site, and any obstruction here would also lead to back pressure, leading to increased intraductal pressure in the main pancreatic duct, the ductal dilatation, and the subsequent complications which can result in acute pancreatitis. Now, this topic is beyond the scope of this discussion. Here we would be more concentrating on obstruction in the extrahepatic biliary system. This diagram also shows the biliary radicals which are present within the liver. Now, dilatation of these intrahepatic biliary radicals is one of the important diagnostic signs, especially on ultrasound abdomen in a patient of obstructive jaundice, which we would see subsequently. Now, to understand the clinical features, the investigations, and the treatment of obstructive jaundice, it is very essential that you understand the bilirubin metabolism. So I've just given a brief overview of bilirubin metabolism in a very simple term. As you see, the hemoglobin is degraded from senescent RBCs in the reticular endothelial system into the heme and the globin component. The heme gets converted into the biliverdin and finally into bilirubin by enzyme biliverdin reductase. This bilirubin, which is produced from biliverdin on reduction, enters the bloodstream, where it is basically picked up by albumin, and this albumin acts as a carrier. Most of the bilirubin would be transported in the bloodstream, bound to this albumin, and it enters into the liver. In the liver, this undergoes what we know as conjugation with glucuronic acid, and this conjugation is facilitated by an enzyme, uridine glucuronil transferase, and this enzyme helps in formation of bilirubin diglucuronide. So basically the bilirubin gets conjugated with glucuronic acid with the help of this enzyme, uridine glucuronil transferase, and the end product is a bilirubin diglucuronide. This bilirubin diglucuronide basically goes into the gut in the second part of the duodenum. And here the diglucuronide component is degraded from bilirubin or separated from the bilirubin, and this bilirubin is converted into urobilinogen, and this conversion is facilitated by the microbial flora which is present within the gut. This urobilinogen, the 85% of this urobilinogen is secreted or excreted via stools after conversion into stercobilin, which gives the stool the characteristic brownish color. About 15% of this urobilinogen enters into the enterohepatic circulation, goes into the liver, and also gets recycled. Some of them enters the blood, gets converted into urobilinogen, which is excreted into the via kidneys into the urine, giving that characteristic yellowish color of urine. And that is because of this presence of urobilinogen. So if you understand this, it's a very efficient way of excreting the bilirubin, which the body doesn't require, and at the same time circulating that remaining part as enterohepatic circulation, which is subsequently excreted by kidneys. This is the same diagram which shows about 85% being excreted and 15% entering into the enterohepatic circulation and finally being excreted from the kidneys. Now coming back to etiopathogenesis. Now this is a very important slide here. Here I would be telling you what are the important causes of obstruction to the extrahepatic biliary system, which ultimately leads to the clinical features, the symptoms and the signs of obstructive jaundice. The most common cause of mechanical obstruction of extrahepatic biliary system is choledocholithiasis. Choledocholithiasis is the stones in the common bile duct. Now these stones in the common bile duct may be primary, that means they are formed within the common bile duct, which is very rare, but the more common are the secondary CBD stones. The word secondary means they come from gallbladder. That means they are already present in the gallbladder, and from gallbladder they migrate into the common bile duct. And these secondary CBD stones are more common and one of the important and most common cause of obstruction of the common bile duct leading to obstructive jaundice. The second equally important cause of obstruction of extrahepatic biliary system is periampullary carcinoma. Now by definition, what exactly is periampullary carcinoma? We'll be discussing that in slightly more detail in our subsequent slides. But the word periampullary carcinoma refers to group of carcinomas which occur within 2 centimeter of ampulla of Vater. And there are different types of periampullary carcinomas. The most common being obviously carcinoma head of pancreas. Another important cause of obstruction to extrahepatic biliary system is biliary strictures. Now these biliary strictures could be benign biliary strictures or it could be malignant biliary strictures like cholangiocarcinoma. One of the classical example of a benign biliary stricture is a post-op inadvertent injury to common bile duct, which may not be recognized at the time of surgery, but subsequently over a period of weeks or months, the patient would come with features of obstructive jaundice. And that is injury which had occurred during the time of surgery basically leads to fibrosis and stricture formation of common bile duct. And one of the most important surgery which can cause injury to the common bile duct is also one of the commonest surgery being done, and that is laparoscopic cholecystectomy. Though the incidence is going down relatively lower now with better training and more commonly this procedure being done. Another common cause of obstructive jaundice is hilar cholangiocarcinoma. Now, this cholangiocarcinoma can occur at the terminal part of common bile duct, where it may be clubbed together if it is within 2 centimeter of ampulla as a periampullary carcinoma, or it can also occur at the confluence of the right and the left hepatic duct, forming the common hepatic duct. This is known as hilar cholangiocarcinoma, also Klatskin's tumor. Mirizzi syndrome is another important cause of obstructive jaundice, which can cause basically obstruction to either common hepatic duct or common bile duct, and it basically is nothing but a stone which is present in the neck of the gallbladder, in the cystic duct, or in the infundibulum, leading to mechanical compression of common hepatic duct which lies adjacent to it, or sometimes common bile duct, leading to obstructive jaundice. Choledochal cyst, one of the congenital conditions, may also cause. Some parasites, though not very common but common in tropical countries like Ascaris lumbricoides, may form mechanical obstruction to biliary tree. Carcinoma of gallbladder and chronic pancreatitis completes the list for other causes which can lead to mechanical obstruction of extrahepatic biliary system. Now, coming one by one to these causes, the first one is choledocholithiasis. As I have already told you, most of these stones in the common bile duct are secondary CBD stones. That means they migrate from the gallbladder into the common bile duct and may lodge in the middle 1/3 or lower 1/3 near the termination of common bile duct near the ampulla. And this can cause mechanical obstruction to the outflow of bile into the duodenum, leading to features of obstructive jaundice. This is one of the most common cause of obstructive jaundice. Now, coming in slightly more detail about periampullary carcinoma. If you remember, I have told you that periampullary carcinoma are a group of carcinomas which occur anatomically within the 2 centimeter of ampulla of Vater. Now, there are 4 common carcinomas which we club together and call them together under the umbrella term periampullary carcinoma. The first one is, and the most common, more than 90%, in fact 95% of the patients would have carcinoma head of pancreas. Now, this is one of the most common malignant cause of obstructive jaundice. Following CA head of pancreas, the next common periampullary carcinoma is carcinoma of terminal bile duct, the cholangiocarcinoma, which occurs near the insertion of common bile duct into the ampulla. And that cholangiocarcinoma would also, if it is occurring within the 2 centimeter of ampulla, would also be labeled as periampullary carcinoma. The third type of periampullary carcinoma is the carcinoma of duodenum. Now, duodenum is not a favored site for malignancy, and this duodenal carcinoma is extremely rare. But if it occurs near the ampulla within the duodenum, then it would be labeled as periampullary carcinoma, which may also cause obstructive jaundice. And finally, we have carcinoma of ampulla of Vater itself, which is again not so common, and it can also lead to mechanical obstruction to the flow of bile, leading to obstructive jaundice. Together, these 4 carcinomas are labeled as periampullary carcinomas, and they form an important malignant cause of obstructive jaundice. I have already told, if you remember, that cholangiocarcinoma may occur near the terminal end of the CBD where it inserts into the duodenum, or it may also occur slightly proximally at the confluence of right and the left hepatic duct into the common hepatic duct. This confluence or this junction or this hilar part goes by the name of hilar cholangiocarcinoma or Klatskin's tumor. Biliary strictures, we have already discussed, are one of the important causes of obstructive jaundice. Biliary strictures, most commonly the benign biliary strictures occurs following an inadvertent injury to common bile duct, and generally we classify biliary strictures in the common bile duct based on this classification system, which goes by the name of Bismuth classification, which is commonly used in biliary strictures occurring from different causes, which also includes the inadvertent injury to common bile duct during surgery. But there is a separate classification system which we normally use when there is a post-op injury to common bile duct, and that goes by the name of Strasberg's classification, which I will not be discussing it here. Now, commonly, what exactly is a Bismuth classification? Bismuth classification grade 1 or class 1 would be when the location of biliary stricture is more than 2 centimeter distal to the hepatic confluence, as shown in this figure. Class 2 would be when it is less than 2 centimeter distal to the hepatic confluence. And level 3 would be at the level of confluence. That means where the right and the left hepatic duct meets to form the common hepatic duct, at that confluence would be level 3. Level 4 would involve either the right hepatic duct or the left hepatic duct, which is basically subdivided sometimes into 3A and 3B in some classifications. And level 5, generally it extends into the intrahepatic branches or intrahepatic ducts, the smaller ducts. Okay, most of these strictures would occur either in the range of class 1 or class 2. So this is a Bismuth classification which we commonly use for classifying the biliary strictures of different causes. Now, word about what exactly is Mirizzi syndrome, which we have seen is one of the important causes of obstructive jaundice. Here, a large stone gets impacted in the infundibulum or in the cystic duct or also in the common hepatic duct or common bile duct. Now, as shown in this diagram, this stone, which is of a significant size, may cause mechanical compression of the adjacent common hepatic duct, more commonly, or sometimes common bile duct when there is a low insertion of cystic duct. And this would, because of this mechanical compression, there may be obstruction to the flow of the bile, and this can lead to obstructive jaundice. Now, Mirizzi syndrome can be an important cause of obstructive jaundice, especially in certain conditions where there are predisposing factors present for development of this syndrome. So what are the different predisposing factors which may lead to development of Mirizzi syndrome? One of the most important predisposing factor is a long cystic duct. When the cystic duct is quite long, the stone may get obstructed in the cystic duct, and that can cause obstruction to the outflow of bile. And the second very important predisposing factor for development of Mirizzi syndrome is low insertion of cystic duct into the common hepatic duct where it joins. If there is a low insertion of the cystic duct, it can also cause obstruction of the cystic duct because of the stone, and that can lead to Mirizzi syndrome. Most of these patients normally present with features of obstructive jaundice and also fever. Now, we have seen different classes of or the different types or the different causes of obstructive jaundice. We'll see what effect or what is a pathogenesis or what pathophysiological changes they cause when there is a mechanical obstruction to the flow of bile into the small bowel. Now, the normal intrabiliary pressure is 5 to 10 centimeter of water. Sometimes what happens, because when there is an obstruction to the flow of bile, there is an increased pressure in the intrabiliary tree, and this pressure may go beyond 10 to 15 centimeter of water. Whenever the intraductal pressure in the biliary tree increases to beyond 15 centimeter of water because of mechanical obstruction to the flow of bile, this would obviously lead to dilatation of proximal part of the common bile duct. When not only is there dilatation of the biliary tree, this dilatation, if the obstruction is not relieved, may also extend into the hepatic ducts and also into the intrahepatic biliary radicals because of back pressure. The second pathophysiological change which can occur because of this mechanical obstruction is that because of increased intraductal pressure, there is a back diffusion of bile. And most of this bile is obviously all this bile is a conjugated bilirubin. It contains conjugated bilirubin. So because of this back diffusion of bile, it is basically picked up by the hepatic sinusoids and the bloodstream and gets circulated in the blood and finally gets excreted in the urine. Now, because of this phenomenon of back diffusion of bile and increased level of conjugated hyperbilirubinemia in the blood, which is finally excreted by the kidneys, all these patients of obstructive jaundice have classical high-colored or tea-colored urine, which we normally see in such patients. And because there is an absence of bile in the gut due to obstruction to the flow of bile into the gut, there is no formation of stercobilinogen, and this leads to pale or clay-colored stools, which are classically described in these patients. So I hope you have understood the pathophysiological basis of these two common symptoms with which these patients come, that is a high-colored or tea-colored urine, which occurs because of back diffusion of bile into the bloodstream, leading to conjugated hyperbilirubinemia, finally getting excreted from the kidneys and leading to a high-colored urine. And because there is no bile entering into the gut, this leads to no formation of stercobilinogen and ultimately clay-colored stools. Now, there's one more important thing which occurs. This bile which is present in gut, when it enters into the gut, it is very much essential for maintaining the integrity of gut mucosal barrier. And I think all of you know that integrity of gut mucosal barrier is very important, because any breach in the or any compromised gut mucosal barrier would lead to what is known as translocation of intraluminal gut flora across the gut wall into the peritoneal cavity, and this would lead to endotoxemia. Most of these flora, especially the gram-negative bacteria, translocate across the gut wall because of compromised gut mucosal barrier, which occurs in a patient where there is no bile in the small bowel. And because of this compromised gut mucosal barrier, there's a translocation of bacteria from the lumen across the gut wall into the general circulation, and this leads to endotoxemia. And that's why these patients are also at risk of development of sepsis. And these patients are prone to develop sepsis because of this reason. Now, another very important complication which we will see subsequently is compromised renal function, which occurs in these patients. And why does this occur? It occurs because there is an acute tubular necrosis. This high bilirubin which is present, especially the conjugated hyperbilirubinemia, it also causes a direct tubular necrosis of the kidneys. And because of this, these patients are prone for renal dysfunction, ultimately leading to acute renal failure. Now, prevention of this complication is very important, and we'll discuss that in more detail in our subsequent slides. So I hope you have understood how the mechanical obstruction to the flow of bile would lead to a series of changes not only within the biliary system but also within the gut, leading to all these complications which we normally come to expect in a patient of obstructive jaundice. There are few other things which also occur when the bile is not entering into the gut, and the most important one is the reduced fat absorption, because bile is essential for fat absorption, and when there is a reduced fat absorption, this can lead to what is known as steatorrhea, where the stools become bulky, sometimes foul smelling and difficult to flush. There is also deficiency of fat soluble vitamins, especially vitamin A, vitamin K. A, D, E, and K. These are the vitamins which we normally require for our so many things, and all these are fat soluble vitamins which we require. So if there is a reduced fat absorption, there is also a deficiency of not only vitamin K, and vitamin K dependent coagulation factors, factor 2, 7, 9, and 10, would lead to coagulopathies and different bleeding disorders, which we again see in these patients of obstructive jaundice. There is also deficiency of vitamin D, and this leads to calcium phosphate metabolism derangement, leading to reduced calcium and its complications. Now, because of absence of bile, we have seen how it compromises the gut mucosal barrier function, but it also compromises the local gut immunity, what we called as GALT, gut-associated lymphoid tissue. It has been seen that there is a compromised or reduced function of T cells as well as B lymphocytes in gut-associated lymphoid tissue. And because of this compromised local gut immunity as well as reduced cell-mediated immunity, these patients are prone for different type of superadded infections leading to sepsis and further complications. We have already seen that these patients are at risk of renal failure subsequently, and we have already seen that endotoxemia is one of the important complications which occurs because of increased gut permeability, and this endotoxemia leading to sepsis may ultimately lead to multi-system organ failure in such patients if the treatment is not initiated immediately. Now we'll come to the clinical features, which is very important, and the most important part when you have a patient of obstructive jaundice is a detailed history. Now there are few points which you would like to ask in a patient of obstructive jaundice. The first and foremost is the onset. That means how this disease was noticed by the patient, how it started, whether it was noticed by the patient himself or herself, or was it told to the patient by the relatives. Most of these patients would come to you obviously with a few important symptoms, and the most common symptom is yellowish discoloration of eyes. Yellowish discoloration of eyes. There may also be yellowish discoloration of skin in late stages when the jaundice is quite deep. Now, when you have a patient with these complaints, you would like to ask few questions in the history after onset. The most important one is about the jaundice itself, whether the jaundice is painful or painless jaundice. Now, painful jaundice, where there is an associated abdominal pain along with presence of jaundice, is classically seen in choledocholithiasis and sometimes also in biliary strictures. And this pain is classically also described as colicky pain. So we have a triad of symptom where there is a right upper quadrant colicky abdominal pain, which we commonly called as biliary colic. Then we have jaundice, and then we also have fever, which may occur with chills and rigors. And this is known as cholangitis. Now, what exactly is cholangitis? Whenever there is a biliary stasis, whenever there is a reduction in the flow of bile or there is a mechanical obstruction, this leads to biliary stasis. This biliary stasis will predispose to proliferation of flora, microorganisms within that static bile, and this leads to ascending infection along the extrahepatic biliary system, and that's what is manifested as cholangitis. We have already seen that these patients are immunocompromised. They are at risk of developing different types of superadded infection, and because of this, the chances of these patients developing cholangitis increases. So fever with chills and rigors, biliary colic, and presence of jaundice is classically what we say as Charcot's triad. If you add mental obtundation, that means the patient becoming disoriented, confused, as well as there's a hypotension where the systolic blood pressure goes below 90 millimeter of mercury, to these already three symptoms, then we call that as Raynaud's pentad. That means the 5 symptoms and signs which are present in this patient. And this Raynaud's pentad, or these constellation of 5 symptoms and signs, suggests that this patient of cholangitis is going into sepsis. So all patients should be initiated appropriate treatment to prevent the progression to such a stage. Another important question which you would like to ask about the jaundice apart from pain is, what is the progression of the jaundice? That means whether the jaundice is progressively deepening from the time it has been first noticed. A progressively deepening or worsening jaundice is classically seen in malignant jaundice like CA head of pancreas or other periampullary carcinomas. Sometimes the jaundice may fluctuate or waxes and wanes. That means sometimes it increases in intensity and sometimes it slightly becomes alleviated and patient symptoms also relieved. This fluctuating jaundice or waxing and waning jaundice is classically seen in ampullary carcinoma. Now, the logic behind this is that as the ampullary carcinoma proliferates, it sometimes outgrows its blood supply and some part of it undergoes necrosis and it sloughs off. When it sloughs off, the slide reduces, the size of the tumor reduces, and some bile flows distally, leading to this fluctuating level. Patient may also have pruritus. Now, why this pruritus occurs is basically, and this is one of the most troublesome symptoms in obstructive jaundice. And this is quite worse at night. That's what the most of the patients would describe. And why this pruritus occurs? This pruritus occurs because of deposition of bile salts in the dermis of the skin. Now, when these bile salts gets deposited in the dermis of the skin, it causes two important effects. One is it irritates the nerve endings, the somatic nerve endings, leading to intense itching. And secondly, the presence of bile salts within the dermis also activates the mast cells. Now, these mast cells secrete histamine, and this histamine is one of the important mediators of the intense pruritus which is seen in these patients. Sometimes these patients also present with metastatic symptoms, especially in malignant jaundice, like bone pains, hemoptysis or shortness of breath, or some seizures which may occur in such patients, or significant loss of weight and appetite. Sometimes these patients also present with coagulopathies and bleeding tendencies like epistaxis, easy bruisability, and that's why during physical examination you must also not only see the scratch marks but also bruises. History of alcohol and smoking is very important, and these are considered one of the important risk factors for development of malignant obstructive jaundice. A family history of any carcinoma or malignancy, especially GI malignancy, should be asked for, and any history of previous abdominal surgery, especially near the hepatobiliary system, or any gastric surgery which may point towards inadvertent injury to common bile duct leading to biliary stricture, should also be asked. On examination of a patient, you may have pallor, icterus, which may be deep, and not only it involves sclera, but it can also involve the oral cavity, especially in the soft palate or the ventral surface of the tongue, and also in the skin. Patient may also have clubbing, palmar erythema, and some stigmata of liver disease like spider nevi, gynecomastia, testicular atrophy, loss of axillary hair. Patient may also have piddle edema because in long-standing cases there may be deranged hepatic synthetic function leading to hypoalbuminemia and piddle edema. Patient may also have left supraclavicular lymphadenopathy, which may suggest pancreatic carcinoma or any GI malignancy. As discussed before, you must actively look for scratch marks, especially in the lower limbs and on the extensor surface of the forearms, and also bruises which suggest coagulopathy. Palpation, examination of the abdomen, if the gallbladder is palpable, then that goes for Courvoisier's law. Now, what exactly is Courvoisier's law? We'll discuss in subsequent slide, but patient may also have ascites and any abdominal lump. Now, what is Courvoisier's law? Courvoisier's law is a very important law which is basically a negative statement, and it always starts with, in a patient of jaundice, a palpable gallbladder is not due to choledocholithiasis or CBD stone or cholelithiasis. So this is a Courvoisier's law, which is a negative statement. The other side of this law means that whenever you have a patient of obstructive jaundice and on abdominal examination, when you are able to palpate a globular, smooth lump in the right hypochondrium, which moves with respiration and which may or may not be tender, and which you feel that is a palpable gallbladder, then the most likely cause of this is a malignant cause of obstructive jaundice like carcinoma, head of pancreas, or other periampullary carcinomas. This is basically what is meant by Courvoisier's law, which would help you in formulating a differential diagnosis, especially on clinical examination. But Courvoisier's law is not foolproof. There are few exceptions to this Courvoisier's law, as shown in this diagram. Sometimes there may be Klatskin's tumor, which we have already seen is a tumor, cholangiocarcinoma at the confluence, and in that case also the gallbladder may be palpable, may not be palpable, but it's still a cause of obstructive jaundice and a malignant one too. And the second one is sometimes a gallbladder may be palpable even in a benign cause, like when there are double impaction of common bile duct with two stones, one in the common bile duct near the terminal end and one in the cystic duct. So these are few exceptions to Courvoisier's law, which otherwise most of the time it would help you in formulating a differential diagnosis. Now coming to the investigations which we would like to do this patient after you have taken a proper history and done a physical examination: complete blood count to rule out any anemia. Coagulation profile is very important, especially the prothrombin time, INR ratio. A complete liver function test to look for serum bilirubin, which would be elevated to more than 2.5 gram per deciliter, depending on the level of obstruction. Liver enzyme, especially the alkaline phosphatase, which is normally elevated more than 4 to 5 times the base value, and that would be considered a significant elevation in such patients. With alkaline phosphatase, we also do gamma glutamyl transferase, because alkaline phosphatase has other sources also, like bone, osteoblastic. So to differentiate whether it is from bone or from the liver, we always do gamma glutamyl transferase. And when GGT is also elevated along with alkaline phosphatase, then we say that this alkaline phosphatase is of hepatic origin. Serum albumin level may be depressed, especially in late stages where the synthetic function of liver is compromised. Most of the liver enzymes like ALT and AST may be normal because the liver parenchyma may not be initially damaged, leading to very marginal increase in these enzymes. Renal function test, because these patients we have already discussed are prone for renal failure in late stages. And finally, few tumor markers to rule out any malignant cause like carcinoma, head of pancreas. So we do CA19-9 carcinoembryonic antigen and sometimes alpha fetoprotein, especially in hepatocellular carcinoma. No investigation would be complete to rule out one of the most common cause of jaundice seen in clinical practice, and that is hepatitis because of hepatotrophic viruses, HPSAG, NT-HBC and NT-HCV, to rule out hepatitis B and C infection. So these are the important blood investigations which you would like to do in such patients. You can also do serum calcium and serum electrolytes. Investigations play a very important role in formulating a treatment plan. Investigations not only help you in arriving at a diagnosis of obstructive jaundice, the cause of obstructive jaundice, the level of obstruction, and it also helps in staging, especially in malignant cases. So we'll see one by one. Ultrasound abdomen is one of the most important investigation which you would order initially in any patient who comes to you and who is suspected of obstructive jaundice. Now, what are the things we are looking for in ultrasound? We'll see subsequently, but the most important thing is a common bile duct diameter. Any diameter more than 10 mm or 1 centimeter would be considered as a dilated CBD, and we have already seen that whenever there is a obstruction to the flow of bowel because of mechanical obstruction, the proximal common bile duct undergoes dilatation. It can also show polylithiasis and IHBRD, or intrahepatic biliary radical dilatation, which signifies a significant long-standing obstruction to outflow of bile. After ultrasound, we would like to do one very important investigation which many authorities consider as one of the gold standard, though it has its limitations, but contrast enhanced CT scan of the abdomen, specifically looking for pancreatic lesions in malignant obstructive jaundice, which may be missed on ultrasound. obstruction in the distal end of the CBD, which again may be missed on ultrasound. So these are the limitations of ultrasound. Very difficult to pick up any small pancreatic lesion, very difficult to pick up any obstruction in the terminal part of the CBD, because the terminal part of the CBD gets obscured by the overlying duodenum, which is gas filled. So these are the limitations of ultrasound, where the CCT abdomen plays a very important role. It is very important investigation for periampullary carcinoma diagnosis as well as staging, to look for any hepatic metastasis, cholangiocarcinomas including Klatskin's tumor. Whenever the ultrasound findings are equivocal, that means we cannot say whether we can rely on ultrasound finding, you would always do a CCT abdomen. And we have already seen that a CCT abdomen is a very important tool for staging, especially in a malignant cause, to evaluate the resectability of tumor. Because as a surgeon, we would like to take a call whether the malignancy which is causing the periampullary carcinoma, which is causing the obstruction, is resectable or not. If they are not resectable, then we would initiate basically some palliative measures. And ultrasound, the CCT abdomen may also miss some small stones which are less than 3 mm. That is one, you can say, drawback of CCT abdomen, apart from a very high radiation exposure. Endoscopic ultrasound, or EUS, is also one of the important tools for evaluating a patient of obstructive jaundice, especially the small distal CBD stones which may be missed on CCT abdomen, small periampullary tumors again which may be missed on CCT abdomen, and you can also do endoscopic ultrasound guided biopsy of the periampullary tumor, which can be helpful in basically doing a staging. We can also do an endoscopic ultrasound guided biliary drainage, especially where the ERCP fails. ERCP is endoscopic retrograde cholangiopancreatography, which we will see subsequently. So we have 3 important imaging modalities till now which we have discussed. Ultrasound, the advantages, which is easily available. Disadvantages, we have already seen what are the disadvantages. Similarly, CCT abdomen, its advantages, where we can use it very efficiently, and also it can miss some smaller stones and small tumors less than 3 millimeters. Endoscopic ultrasound, its advantages and its drawbacks. And finally, we have MRCP, or magnetic resonance cholangiopancreatography. It not only tells you the level, but also the cause and the severity of obstruction. It is excellent for biliary tree anatomy. So if you want to study the extrahepatic biliary tree anatomy, or even intrahepatic biliary radicals, MRCP, or magnetic resonance cholangiopancreatography, is one of the very important investigation. It is very highly sensitive and specific for obstruction. It can detect stones even less than 3 millimeters in size. And it has practically replaced ERCP as a diagnostic tool. In today's world, ERCP is only used for therapeutic purposes, and it has been replaced by MRCP and other non-invasive methods as a diagnostic tool. Please remember this in your mind. Now, this is what ultrasound which I was talking about, how it looks like in obstructive jaundice. Here you can see a dilated CBD in the picture, as well as IHBRD, intrahepatic biliary radical dilatation. You can also put a CBD stone, we can see on ultrasound. As discussed, we can see liver architecture. Periportal lymph node enlargement can also be picked on ultrasound, and presence of ascites can also be seen on ultrasound. CCT abdomen, as the picture shows here, there's a pancreatic mass, the arrow which is shown here, and this pancreatic mass in the head of the pancreas is causing obstruction to the flow of the bile, and this leads to back pressure on the main pancreatic duct. So you can see the arrow in the second one, the B, where the main pancreatic duct is dilated. CCT abdomen is very important tool for evaluating in terminal CBD obstruction, periampullary carcinomas. Classically, we use triple phase helical CCT abdomen, and it is very much useful not only to know the resectability of tumor, but as a part of CT tab, that is CT of the thorax, abdomen and pelvis in staging of malignant obstructive jaundice. This is a MRCP which is classically seen, which shows the hepatobiliary tree anatomy. And here you can see that there's obstruction near the distal end, and this leads to not only the proximal dilatation of CBD, but also the main pancreatic duct is quite dilated. And this is a classical sign which is seen in MRCP, what we call as double duct sign. This double duct sign, where both common bile duct and the main pancreatic duct is dilated, is classically seen in any periampullary tumor near the ampulla. Role of ERCP we have already seen is more of a therapeutic now rather than diagnostic, and its main role is the stone extraction from common bile duct, which is lodged near the terminal end of common bile duct. It can also be used for biliary stenting, especially as a palliative procedure to alleviate the symptoms of obstructive jaundice. It can also be used for dilatation of any biliary structure with balloon dilatation, and you can also take brush cytology of any periampullary tumor during ERCP. Though it is commonly performed procedure, but it has its own complications, which fortunately are quite rare. One of the important complications is post-ERCP pancreatitis, which may occur in 3 to 5% of patients. It can also lead to duodenal perforation. That's why any patient coming back from ERCP, you should always be careful about this perforation and keep a close watch on abdominal finding. It can also cause bleeding, especially in patients with coagulopathies, or it can be a source of infection leading to cholangitis. Now we'll try to finish it off with some treatment. Treatment would depend on the cause, the location, and the degree of obstruction. One of the commonest cause we have already discussed is choledocholithiasis, or stone in the common bile duct. If a stone is present, ERCP with extraction of stone is one of the commonest therapeutic procedure which can be done, and the results are quite good. 2 failed ERCPs on stone extraction would become an indication for open surgery. Okay, surgical, because most of these patients have secondary stones, so gallstones may also be present, and subsequently that has to be dealt with laparoscopic cholecystectomy. Sometimes we can also do a laparoscopic CBD exploration, especially in cases of failed ERCP. If the cause is malignant, like periampullary carcinomas, which form another major cause of obstructive jaundice, then depending on, say, CA head of pancreas, which would be seen in more than 95% of cases, we would try to see, based on the investigations, what is the stage of the disease, and secondly, is there any metastasis or not. So basically, we want to know whether the tumor is resectable or unresectable. What are the characteristics of resectable tumor? That means the tumor is confined to its organ, that means in the head of pancreas. It has not spread into the surrounding structures. Number 3, it is not involving any major vascular structures like portal vein or any arterial involvement. And another important thing is it has no distant metastasis. If all these criteria are met, then we can go in and classify that tumor as resectable, and patient, especially in CA head of pancreas, would undergo what is known as Whipple's procedure or Whipple's pancreatico-duodenectomy. If the tumor is unresectable on your investigations, that means it has already spread beyond its organ, beyond into the surrounding structures, or number 2, it is already surrounding or engulfing the major vessels in the vicinity like portal vein, or number 3, it shows distant metastasis. So in such cases, we can only do palliative procedures, which become quite useful, and the aim is to alleviate the symptoms of obstructive jaundice, mainly the pain, the jaundice itself, and pruritus. So in that cases, we can do stenting via ERCP, which we have already seen. We can also do stenting while doing endoscopic ultrasound, which we have already discussed. Or we can also do, if it is a biliary stricture, a balloon dilatation. Or we can do some surgical procedure like Roux-en-Y choledochojejunostomy to bypass the obstruction. PTBD, or percutaneous transhepatic biliary drainage, is another important procedure which is generally done in such patients, and the indications are quite clear here. Whenever the endoscopic retrograde cholangiopancreaticography or ERCP fails, due to stenosis, in that case, we can resort to PTBD. That is one of the main indications for doing a percutaneous transhepatic biliary drainage. Failed ERCP due to stenosis. Number two, when there is a very high biliary obstruction like Klatskin's tumor. In such cases, PTBD would be an ideal procedure to be done rather than doing a stenting. Number three, when the patient is already in acute cholangitis with sepsis, you would also do percutaneous transhepatic biliary drainage for biliary decompression when the patient is planned for surgery. So if you have a very deep jaundice, patient is resectable and you have already planned the patient for surgery, but you want to do a biliary decompression before surgery, then PTBD would be an ideal procedure. And finally, as a palliative procedure to relieve the symptoms like pain and pruritus, which we have already seen. So these are the few indications for PTBD: failed ERCP, Klatskin's tumor, biliary decompression before surgery, palliative procedure to relieve symptoms like pain and pruritus, and finally acute cholangitis. So it's commonly PTBD utility is seen in pancreatic carcinoma, C. pancreas, Klatskin's tumor, complex choledocholithiasis or primary sclerosing cholangitis, which may be seen in few inflammatory bowel disease conditions. Generally, PTBD would be contraindicated if the patient has uncorrected coagulopathies, which can lead to complications like bleeding. Or if the patient has massive ascites, then also we would be hesitant to do this procedure. And obviously, if the biliary tree within the liver especially is undilated, then we cannot cannulate that, and in that case PTBD would not be useful. This is what the PTBD looks like, where, as the name suggests, percutaneous. So from the percutaneous, we cannulate the dilated intrahepatic biliary radicals, and then we can do different procedures like you can inject a dye and see the biliary anatomy. You can also put a stent, and we can also do biliary decompression by collection of bile externally. There are other supportive cares which I have to give in these patients, especially to reduce, especially the pruritus. We can give cholestyramine, which are bile salts, which can bind the bile salts, or also deoxycholic acid. You can also give antihistamines for pruritus. Nutritional support, because many of these patients are nutritionally depleted, high calorie, high protein. Enteral diet is preferred, which would restore the gut barrier function. If enteral feeding is not tolerated by the patient, then total parenteral nutrition or TPN can be used. Fat soluble vitamin supplements should be given, especially A and vitamin D. For coagulation, because these patients we have already seen are prone for coagulopathy, injection vitamin K 10 milligram at least for 3 to 5 days should be given to correct the coagulopathy. We can also give FFP or fresh frozen plasma to correct coagulopathies. Maintain adequate hydration, as these patients are generally hypovolemic because of third space sequestration. So give a subsequent adequate IV fluids to maintain renal function and correct the electrolyte abnormalities. These patients we have also seen are prone for infection. So broad spectrum antibiotics, especially piperacillin, tazobactam, cefoperazone, sulbactam, or ciprofloxacin, which is excellent for biliary penetration, along with metronidazole, is an ideal choice. Antibiotics may be required for a longer duration, for up to 14 days, so sometimes 3 weeks. And for pain management, we may have to give, especially in late stages or in choledocholithiasis, we may have to give NSAIDs or opioid analgesics depending on severity of pain. Now, the complications with which these patients are prone for they are prone for suprahepatic infections leading to sepsis. They are also prone for acute renal failure, different coagulopathies leading to bleeding tendencies. They can also have nutritional deficiencies, liver dysfunction, and multi-organ failure. Any patient who is going for perioperative surgery, you have to optimize this patient, and there are 4 things which we would take care of in a patient of obstructive jaundice who is going for any procedure, especially surgery. One is hydration, so correct hydration by giving IV fluids, nutrition, enteral and TPN, infection control, antibiotics, and coagulation by giving vitamin K and FFP. with this, we have come to the end of this presentation. I have given you few MCQs. In your spare time, you can go through those MCQs and try to solve them. Understanding all these MCQs are designed from whatever we have still discussed, and try to give your answers in the comment section. I hope you have liked this video, and if you have liked, please subscribe and recommend my channel to your colleagues and friends, and also give a WhatsApp sign to me, thumbs up sign, sorry. Thank you.